welcome to the Ankleman podcast. I'm here with David, and today I think one of the things I wanted to talk about was MIS. It is obviously a big deal in foot and ankle surgery. I hated MIS when I was younger. I actually published an article on it that I'll get into, but it's really changed my practice. And I know David does a lot of MIS too. So we wanted this podcast to kind of be like how we got into MIS and how it's changed our practice, but focusing mostly on the forefoot for now, and then we're going to get into all the wild stuff on subsequent podcasts. So thanks for joining us.
Perfect. Thank you for having me.
Absolutely.
I know you have some cases to start out with, or
yeah, I'm just going to start out not with the cases itself, but with this article. So every time I go to any MIS course, everybody brings up this article, and they all make fun of me for it. So I wanted to hit this article. It's now about 14, 15 years, maybe even longer now since I did this article, but this was done, it's kind of like we have literature, we think we know the answer, and then we follow it. But what I've learned a lot is, and I think you've noticed this too, everything changes, right? We keep changing. So one of the topics I think we want to do was like articles that changed our practice in the past. The problem is you have to make sure that you don't just adhere to that one article, right, man? Don't you think like you may have had the seminal article when you were 5 years out of practice, but now 15 years, you no longer do what that article says, right?
Right. For sure. Yeah. Like FHL transfers, those kind of things.
Yeah. Like I haven't done an FHL transfer except for revision. I do like one a year now, where before I was doing, when I was at Michigan for Achilles, that's all I did, totally different.
Right.
So this article was our attempt when it first came out when I was in fellowship, and I'm usually known for maximally invasive surgery, but I do a ton of minimally invasive now. And what you can see in this article was the question is when something goes wrong, and this is how I think about things too, when you get a bad outcome, you should always ask yourself, I don't know what you think, David, was it me or was it the technique? And then sometimes is it the patient's compliance, biology, et cetera, obviously, but assume these patients are healthy. And that's kind of how I think about it.
Right.
I don't know if that's your thought process too.
Definitely. Yeah. I would say 50-50. Half the time I blame the patient more, but it's just my patient population, like we're in Southern Maryland, people are not the most compliant. So
so that's true. Sometimes it is the patient's fault, but when we do literature, we're like, maybe when we did this article and the minimally invasive bunion surgery did really poorly, but it could have been us. And so over time, we learned that in retrospect, this actually was us. It's not the technique, which I think is really important, right? We used a tiny incision. We didn't have those fancy burrs we have now. So we just did a saw or a burr, and the periosteum was only elevated at the level of the osteotomy. That's what you're supposed to do. We kind of just elevated the periosteum like we usually do. And so, our results weren't great. We kind of tried, and we just were technically not as proficient, nor do we have the equipment to do what was necessary. And so we did all this stuff. We did K-wire fixation, which was the Seri technique. And you can see, it doesn't look that bad. This patient had a lot of arthritis, but it, decompressed it. But when you look at it now, it was basically an open osteotomy in hindsight and really didn't get the hematoma or the callus, right? When we look at how our MIS bunions heal now, there's a ton of callus, right? Don't you see that? Mostly lateral first.
Mm-hmm. It fills in, yeah.
It fills in. Our cases had none of that. So we weren't getting that preservation of hematoma that would allow you to get that secondary bone formation. Well, we noted that we got good correction intra-op. You can see that here. We got it to look pretty good in all angles, but then you could see they came back. They started coming back a lot, and we got a lot of dorsal angulation because it was just a K-wire.
Right.
And I don't know. I presume, maybe I'm wrong. Do you use a K-wire or using screws now for your MIS bunions?
Nowadays, definitely screws. I actually started out with screws. I know Siddiqui up in Baltimore. He's been using big Steinman pins and K-wires to kind of shift it's almost like a bullet, like from the Enovis system, like he shifts it over. Yeah.
Sure.
And then he pins it down before the screws were, but he kind of started that, and then screws came out, and that's when I jumped on 2019. So.
Gotcha. So you're before me. I'm like a 2023 guy, 2022 guy. I think one of the reasons why K-wires, I think we abandoned was because of this. Like we did get dorsal angulation, and if you get that shift really hard and the soft tissue's tight, then it may not shift. But screw, I
Mhm.
think, mitigates a lot of that. And then we got a
What's
lot
your post-op protocol for these? Like, I mean, back then.
back then. We let them weight bear in a shoe because that's what was described in Italy, man. Like we kind
Mhm.
of took the Italian data and they let them weight bear with some strapping and said it was okay. But I'll tell you, they did a lot of strapping too, which in Italy and I think in Europe, there's probably a lot more. Um, they come back a lot more. They're able to control things a lot more. And back here, having a patient come back every week for
Yeah,
strapping is super hard, right? What patient wants to drive in every week? To see me, you have to drive to the city, which nobody wants to do, right? You got to pay like $17 for parking. Takes 3 hours to get in and out, assuming I'm even on time.
right.
It's a big burden for the patient actually.
Yeah,
So it's so I think it's not we can't strap as well as they can in maybe like a small suburb and things like that. So for me, it's not practical.
right.
And in Baltimore, it did not. We were not strapping as well as they were in Europe. I think strapping is a big deal if you can use a wire.
Mhm.
Screws make it easy for the Americans. Like it works for us. You know what I mean?
Yep, we're all about internal fixation for sure.
100%. So, and then we got a lot of bad outcomes. Right? We got malunions, recurrent bunion, non-union. Now, non-union really occurs when you do it with the proper technique, but saw gives you heat necrosis, things like that. We got osteonecrosis. We got some issues. So we ended up publishing this that this was not a great idea, and probably at the time it was right with the equipment that we had, with the techniques we had. No concept of internal fixation probably wasn't the best way to do a bunion in like 2007, 2008.
Right.
um but the good thing I think is that people, although it really killed MIS in America for a long time, the Europeans kept hard charging. A lot of Americans kind of picked it back up again because I know it started decades ago. And so in hindsight, long story short, it was us, and even I went to a course. Many of you know I don't really go to listen to anyone. But that's been since I was a kid. I have a hard problem listening to people. But I went to a course. I learned Acevedo, Becky. They taught me stuff, and so I've kind of now jumped on board. I think it's a great way to do things. And I grew up on Star Wars. I don't watch as much anymore, but this is a Yoda quote. And I think this is a big lesson for us as surgeons because we never want to admit mistakes. But I think if no mistake you have made in this the quote, yet losing you are a different game you should play, which means if you're not willing to not, and nobody wants to have a mistake on a patient, that's very important.
Sure.
But as surgeons, you're never going to get a perfect outcome every time. You have to try to improve. And if you never want to have a bad outcome or never want to have a complication, you're not going to grow. And I think that's
Right.
what the quote's implying, right? I mean, I don't know if you have the same philosophy or not, or is it always just play it safe, play it safe? Is that how you think?
Uh, I because of 15 blades, I am on the more cutting edge of stuff. I like to try new things, assuming I am comfortable with the technique. I tried different IMALs, I tried, different MIS systems. I probably tried every single system on the market right now. And I can technically make them all work. It's just I want to learn, I want to know what's out there. And as long as I feel like the system is not going to detriment my patient's progress or violate any, I know, general surgical principles and stuff, then I'll try them. I mean, that's my philosophy. But, a lot of people are very conservative. They'll stick to one total angle. They won't change, right? Like, that type of thing. So,
I mean, I get it. And they always say, right, you never want to be the first person, never want to be the last person. And as new thing comes out, I was definitely not the first person on MIS. I do a few things that I'm definitely the first person or very early adopter person. But you go to the lab, you check it out. You don't just try it. When I did MIS,
agreed.
did a course, right? And then before my first MIS bunion case, I went back to the Arthrex lab, tried it again, made sure I knew what I was doing. And I was honest with the patient. I'm like, look, there's a new technique. I'm going to try it. Are you willing? And they're like, if you're honest with the patient, I have found, and I'm not telling you I'm perfect, but the more honest you are, the more willing they are to understand. Like, look, I can do it this new way. I think it's better. I've learned on it. Or I
Right.
can do the way that I've done it for 20 years. What would you
Yeah.
like? And patients are pretty reasonable. So in your hands, David, like, and we're not here. We're not trying to sell a system to anybody.
Sure. Yeah. Go ahead.
obviously I use the Arthrex system and I think it's great. But the point is, in general, do you think your MIS bunions are better than your open osteotomies? Let's just start there for now.
For now, since I've been doing it for so long, yes, definitely. It cuts down my surgical time. It really makes the foot look so much better clinically. Radiographically, I'm going to say sometimes I get the bone callus, sometimes I don't. I would say that's more of a 50-50.
Okay.
But generally 99% of the patients do very well with it. I do have screw backage from time to time, especially with certain systems, a little bit more than others. But I do early wake on my patients, so I think that might be a factor to it. I do have MIS hammer toes as well, so those screw backage I definitely see a lot more than I would see before I did MIS. I mean, I'm going to tell you, my first MIS was actually maximally invasive. I opened it up and just did the MIS technique. It was
Oh,
a
really?
revision. Yeah, I opened up. I want to see everything. I want to see how the cut works. And I shifted it as maximally I can, but I could see everything. And then I put the 2 screws in and the Aiken. And, it was a big medial incision. It was a revision from someone who did a lapidus that failed. The lapidus healed, but it wasn't corrected. So I opened everything up medially, and then that's so it was MIS, which is maximally invasive surgery. So
That's awesome. So
yeah,
I think there's two points there, right? These really do work. And if you look at the data, this is just one article with Holly Johnson and Cesar Neto and a bunch of people that do MIS, is that it works, right? Your IM angle corrects. And again, I'm not selling anything here, but I just want the point that MIS surgery works. The data is out there. These are multiple articles now from 2021, 2016 to 2022 is this article. And it really corrects your IM angle or HVA. Now, IM is measured center of head, right? Because it's not changing the shaft. So here's a question. So let's suppose we both believe this works really well. What do you tell your patient about the x-ray? Do you show them an example of the x-ray? Because if you don't tell a patient what it looks like and they go to the first post-op and they see that x-ray, most people react with what the hell is that, right? They're like, whoa, what did you do? It looks crazy, right? If you're at the first course I went to, I was like, that looks nuts. No way. I'm dead serious.
Yeah, the first words that came out of my mouth was WTF.
Seriously, you guys are nuts. So how do you convince the patient, explain to the patient that this is not crazy? Do you show them the x-rays? Do you show them some post-ops? Do you have a handout? Is there a website? Because I think, the audience that may not be doing a ton of MIS, like that's a big deal, right? Because patient may freak out.
I actually keep a small collection of MIS pre and post-op x-rays on my phone. And what I do is I'll show them, like, this is what it looks like before. This is what it looks like after clinically. This is your x-ray before, this is your x-ray after. Kind of like a example. My patients are a little bit more, I don't want to say gullible, but like they trust me more, probably just because of the location where I'm practicing. You practice more in the metropolitan area, so people come to you for like third opinion, fourth opinions. I don't get that as much. I usually second opinion or third at most. And so I don't get patients that are kind of very skeptical of me as much as some people will practice, let's say in central DC or something like that. So and so it's a little easier on my practice, and I don't have to explain as much, but that's usually what I do. But
Gotcha. I think that phone thing is great. Having a library, like plastic surgeons, what I've learned is plastic surgeons will have books, right? But obviously we are not plastic surgeons, but bunion surgery is probably the closest thing we get to like plastic surgery, right? Because cosmesis counts. And they have books in their office. Like when we were students, that's what they have. And I think everybody who does MIS should have a library like you have. Have it on your phone, put it in a folder. Like I got a bunion folder. If you have I have Instagram, so I use my Instagram. That's my cheat. But you can have a hammer toe folder so that patients know, hey, this is what it looks like at pre-op, post-op, 6 months, where the calf's going to be. They don't get shocked after surgery. I'll tell you one crazy story. I did a fusion on a patient. Post-op patient was very upset. There was metal in the foot. And I don't know if you've ever experienced that. I mean, the patient was livid.
Yeah.
Why'd you put metal on my foot? Initially, you're like, well, how can the patient not understand that? But then I thought about it. I said, well, I never probably showed them what a fusion looks like.
Yeah.
And we used a bunch of words and they have no idea what the hell we're talking about. And so now I would show the patient the x-ray every time. Google is great. It doesn't even have to be your own x-rays because of HIPAA and stuff like that. It can be hard. I'll just go to Google and, MIS bunion, it'll show up. This is
Right.
kind of what it's going to look like. So, and I think that is a big deal, especially for MIS, because the x-rays look wild. I swear to
Yeah.
God, they look wild. So you have to convince the patient and yourself that it's okay.
Right.
Um, and I know there's a lot of pressure for this. I don't know how much pressure you see in your area, but I think in the last couple of years now, MIS, bunion, minimally invasive is sold by like the companies have putting pressure on us, your colleagues. So if you're not doing MIS, especially as a young surgeon, I think you're
Kind of
gonna have,
missing out. Yeah.
right?
Yeah.
You
It's
know, I,
kind of like when lapiplasty came out, like patients will come in asking for lapiplasty instead of Lapidases, and like it's the same thing.
right. You gotta spend 10 minutes explaining to them it's a 100-year-old procedure, but marketing is powerful.
Right.
MIS is that way now. So here's the thing, so when I started my bunion career, I did osteotomies for a while. I didn't like it. Then I opened osteotomy. So I started doing a lot of Lapidus, and Lapidus is really, really good when you get it perfect. But
Right.
when you get it wrong, either IM angle is not great, rotation is not great, or it's slightly dorsiflexed, or you get a non-union.
Right.
Now went from not a problem to like a royal pain for both the patient and yourself, right? So I basically abandoned Lapidus only for revision, unless it's like a severe, severe flat foot that I'm doing a huge recon on. I don't do Lapidus. I'll do this for almost 95% of my patients. So does my partner. So the question is that the same for you, or do you have like MIS
I,
bunions for a tiny portion of my practice?
no, I haven't done a Lapidus since I can't even remember when, to be honest. Like I just haven't touched it. I remember Diffuse Synthes came out with their Lapidus kind of jig or whatever. And then Stryker came out with their version of it. And I think that was kind of big. I want to say a year or two ago when they came out with that stuff. And I met with a VP of one of the companies and I told him, I was like, you guys, I mean, this is a good product, came out Lapidus, makes things easier. You're copying Lapiplasty, that Treese product, but I think this market is going to shrink. He didn't believe me.
You're
And
right, though.
finally, I had to sit down with him and I did a whole presentation on MIS surgery and what I've done with MIS, with fusions, all kinds of stuff. And then he finally started to kind of see things differently and they're developing their own system now. So I mean, obviously it's like a Me Too thing, but like, it's almost like this thing is going to take over. I have surgeons pushing, I mean, not surgeons, like reps pushing me plates, staples and stuff like that for fusions and stuff. And I tell them like, half the time I do MIS and I don't need these staples. My incisions are this small and you're trying to sell me something that I have to open the incision this big. Now I'm not saying they don't have a place. I'm just saying, for a primary surgery, I likely won't need them.
No, I agree. I think the time, there's a song out there, the times are changing.
Yeah.
Times are definitely changing. I think like staples clearly have a role. In many cases, we're still going to do some open stuff, but you're right.
Sure.
New generation of screws, new generation of jigs. Obviously, I'm pushing for that too with the with Arthrex and stuff like that. Because I do believe the winds of change are here, right? It's going to be MIS. You're still going to open things. They're just
Sure.
how life is.
Yeah.
But we need to make the MIS easier, right? It's such a technical challenge right now because it's all mostly freehand and the jigs are like all big and janky. There's so much more to go with navigation and stuff like that too. So for the audience, I mean, I think MIS, one of the lines that I use a lot, man, I'm sure others do too. It is the arthroscopy of the sports world, right? When arthroscopy came out, people would laugh at you. Why would you do a arthroscopic rotator cuff repair when I can do it through 2 centimeter incisions? And I remember hearing those lines. Well, now no one does an open rotator cuff. It's
Yeah.
like insane, right?
Right.
But the initial time would take you like 4 hours for an arthroscopic rotator cuff, and the open dude will be doing it in like 30 minutes. But I mean,
Yeah.
that's no longer the case, right, man? I mean, so
Yeah.
like for
You can't
us,
do that. You're
you know,
outdated if you do it. So
outdated. Like I bet you
yeah.
in 5 or 10 years, if you're not doing MIS budgeting, people are thinking, what's wrong with you?
Right.
So this was one of my older cars that I had. As those of you that know me, I have a financial stupidity in my mind. And I will tell you, there's no amount of cars that ever make you happy, but patients have done better. You can do it for a lot of things. And that's what I learned. I thought it was just like a bunion thing and a calcos, everything. And what David's saying, and we'll get into this with the other cases. This is for anytime you got to cut a bone or a joint. First thought should be, can I do this with the burr? And then do I need to do it open?
Right.
So this case, I would tell you, I used to hate bunions, and I don't do a ton of them as much anymore because I got some younger partners that do a lot more than I do, and I have an unusual practice, but I still do these. And I used to hate this because of stiffness, cosmesis, and recurrence. I just couldn't figure out how to get it right, right? And Kalikian, who's, my one of my mentors and colleagues, always says, if there's so many operations for it, none of them really are great, right?
Right.
Now, there's 175 or 200 of these operations, but so many people, once they get to MIS, like, that's it. That's your stick, man. And I think this is the key to the bunion. This is one of my very early ones, right? It's a minor shift, all that kind of stuff. And I did not like this x-ray at all. You're like, oh man, it doesn't look that great. But then you just wait and they just get that callus, right? When do you see that callus? So for people that are doing MIS bunions, the 6 weeks x-ray, the patient's like, it's not healing, right? The radiologist might overread your x-ray. They'll show no evidence of healing, non-union, or they'll torture you.
Yeah,
so
they will. Yeah.
Right. So at 3 months, you see it on the lateral cortex many times. Still don't have to, but that's when I see it. That lateral bone starts to heal. Is that kind of the timeline for you?
Yeah, it's usually 3 months plus when I see them. I tell my patients it's going to be 6 to 10 weeks. Some people 6, some people 10, most people 10 when you start seeing stuff after MIS. But I weight bear them a little earlier before that. So, I mean,
Are you weight bearing
obviously,
like out of the office, out of the OR?
Out of the OR, their heel touch weight bear once their stitches come out, which I don't even do. I switched my practice to non-absorbable stitches, so I don't even have to take them out. So
you
like
just put
2,
like
3,
a little monocle or something like that?
yeah, just a monocurl, and it works out great. And so less pain for the patient in the office. They love you more. But like around like 2-3 weeks, I let them like full weight bear in a sneaker if they can fit.
No way.
Most of them are a little bit swollen, so they can't do it. But like usually around 6 weeks, they're in regular shoes. But that even 6 weeks, I do say when I see the X-rays, they're not fully healed. You probably see like 30% maybe or 40. Yeah. I mean, I'm being very honest, like looking at the x-ray, they don't look fully healed, but when you press around the osteotomy site and when you examine them, they don't have any pain there. So it tells you it's stable,
Stable.
So in that sense, I'm like, you could start walking, you have more healing to do, but you could start doing like ambulation and normal low impact stuff. So, yeah.
So here's a question, 2 of them for you. How often are you doing an Aiken? I started off doing it not too often, was not satisfied with the cosmetic appearance. So I do Aiken 99% of the time now.
Yeah.
And then 2, I think the early weight bearing gets it to heal better than keeping them off of it, because that's how you get that micro, you get that callus, right?
Yeah, I always say weight bearing definitely heals faster. I would say Aiken for me is 50-50. Surgery centers are kind of weird, at least in Maryland. I know a lot of docs are pushing for Aikens for 99% of their patients, and they'll do them no matter what, and part of it has to do with, I think part of it has to do with the billing. If you're doing it at a surgery center and you don't, obviously I'm in private practice, that's why I'm saying this. If you don't do an Aiken, I think if you do an Aiken, you bill a double osteotomy, right? So that code is different than if you just do like a head procedure without an Aiken. And I think with the cost of MIS screws and the construct, depending on how they cap it at the surgery centers, If you don't do an Aiken, your surgery center is going to lose money on that bunion case.
Fascinating. See, I don't have that experience because, as many of you may or may not know, I work at an institution, Northwestern, so we don't see that.
Right.
So
I mean, I encourage the companies to drop their prices for surgery center pricing because,
yeah,
you want this to be popularized. That's how it's going to be, because a lot of these cases, you're not allowed to do them at the hospitals anymore, at least in Maryland or Virginia. Like, you have
I
to do
know.
them at the surgery center unless you have no surgery center affiliation. Like, they kick you out. So
Really?
it's not even, and
It's not
that's
even
probably
an
going to
option.
be the trend, so.
I think so. I think we're going to see it here too. I hope I retire by the time I'm forced to leave my privileged little practice that I have,
Right.
And these are the clinical pictures. And I think this is the sell to me. When I look at these pictures, there's soft tissue damage is minimal. It's like 3 or 4 tiny incisions, and they love it. I mean, their
Yeah,
satisfaction is
cosmetically
high.
pleasing.
Please, in
Sure.
6 weeks, they're in a shoe. I put them in a boot for 6 weeks to let them walk because it's easy, kind of routine for me. But by 6 weeks, almost everybody's in a shoe, right? That seems to be the case, and that's the deal. This
Right.
motion, I could never get with open at 6 weeks, man. Never.
Yeah, they're scarred when they're open. Yeah.
I think that's a big deal. That's a huge deal. So these are just some cases I did early in my time. Bad bunion arthritis, and I would argue this is not a great job that I did, but look at it at 6 months, it's back a little bit, but patient's relatively happy. These DMMOs heal. This patient had a low bar, kind, older patient, just didn't want that huge bump. But one thing you'll see is that the screws, this one's a little close to the joint.
Right.
And what you talked about, there's some screw migration. That's why I wanted to bring up this x-ray. What do you do when you look at the lateral of your x-ray? Do you care if the screw is plantar, central, or dorsal? If you had to pick one of the three, central being the best. But if you had
Central is
to,
obviously the best. Dorsal plantar is not the end of the world as long as it's within the cortex. And I've done like 1 or 2 patients where when I saw a lateral, it was poking out a little bit. And I didn't want to mess with it anymore. This was earlier in my practice for MIS, and later on I just have to pull them out. But I will tell you, because I weight bear these a lot earlier than some of my older patients that before MIS, I do feel like the chamfers on the screws, when the screw kind of backs out and rotates, they poke the patient.
oh yeah, sure.
I mean, you could feel it under the skin. Like, I mean, screws, they rotate. They don't stay where they want to be, especially when you're early weight bearing. So I feel like I definitely do a lot more hardware removal than I used to for like a regular bunion with the MIS. But I mean, that's just part of the the process, I guess. Now
I think it's worth it,
there's
man.
companies out there, and I won't name who, but their chamfer screws actually, they cut off the sharp edge of it, and so when it rotates, not as bad. But most companies out there, they have a very sharp chamfer.
Yeah, sure.
So I
I'll
mean, you
make
can feel it with your thumb when you're in the OR.
Oh yeah.
It's not
If it's
pleasant.
like off, it's like a sharp knife cutting
Yeah.
at you. Yeah.
Right.
And I think a lot of these, like, when you start doing MIS, there's new complications you're going to get, new issues. You just got to tell the patient, like, look, I'm going to do all this. You may have to get the hardware taken out if the screws back out or screws get loose. Just that unknown where the patient's like, well, what do you mean the screws move? They get really angry, really upset. But in like these poor quality bone patients, you might get some motion. And you just warn them, like, look, it's still better than filleting the toe. Even with that hardware, it's still better than filleting the toe. And I think that's the key here. So here's another one. 81 years old. It's going to weight bear, right? A lot of these patients are older. They live alone. They have to walk on it. If you tell an 81-year-old you can't be weight bearing, it's like unsafe for them, right? I've had patients break their wrist and hip and all sorts of terrible things. So what do you do now? Like, this is where MIS, I think, is huge. Small incision. You get a good correction. Is it perfectly cosmetic? No, but just remember where you started, right?
Right.
Now I'm a big fan of telling patients, look where you started. look where we ended. And even if it's not a perfect x-ray, you can see how early this is. This is pre-beveled screws for me.
Mm-hmm.
You
Yeah.
give the patient a foot that doesn't hurt without the wound complication, right? I mean, all of us had a wound complication, 80-year-old or something stiff. They hate it. It's a disaster. So, I mean, I think like it allows us to treat a wider population of patients. Do you think that's the case? Because when I did it open, I'm like, I think you're too old. I think, I don't know. I don't want to. But now I'm like, I can help more people. I think that's what I'm trying to say. I don't know if you found that out too.
Yeah, for sure. Like eye nails, like, when I do like DTC fusions MIS way, for older 90-year-old, I don't want to, let's say they have a big pylon fracture or something. I want to put an eye nail in. I don't really want to open them up too much. Then MIS is perfect for it,
Yeah.
That's funny because I just have a case coming up this week too for that. So
I think it's a huge deal for treating more and more population without saying, well, it's a known risk. We always say, well, it's a known risk to get a wound complication. I still know that. I still get wound complications, and I tell the patient, no, it's a known risk. But if we can make that known risk even smaller, right? When an older patient or anybody gets a wound complication, it really annoys them, ruins their life sometimes. They got to go back to work. They can't go swimming. They can't get it wet. They're losing their mind. If we can keep that as low as possible, I think is better. When I tell a patient actually is it's easier to deal with the non-union than it is a wound complication. I don't know if that's
agreed. Absolutely agree. There's no
know?
question about that. Yeah, for sure.
And for me, when I started thinking about it, that was, MIS makes sense to me. If I can do it MIS, and even if I get a non-union, because I'm not seeing it, and I will tell you my non-union rate with MIS is super low once you get good at it. It's easy to revise these, but getting a wound complication, there's no easy way out of that. It's a disaster.
It is. I'm lucky I have like podiatry partners that do a lot of wound care, so I can punt it to them. Very lucky that way. But I completely understand where you're coming from. Like this is, definitely MIS is the way to go for these. Do you do a lot of fusions with MIS as far as the first MBJ fusion? What's your criteria? Between doing a bunion versus a fusion.
I think it's a great question. I always look at the great toe as there's never been a dissatisfied fusion patient that accepted the lack of motion, right? Patients that refuse to accept the lack of motion, they hate fusions. But if they don't want to have pain and they want a straight toe, fusions always do great. So I'm always happy to convince someone to get a fusion because when they work great, and they work most of the time. But my algorithm is obviously if they're older, there's any arthritic changes, and once you're 65, 70, I think it's much more reliable to do a fusion, obviously. Sure. And at that age, I'll try to do it MIS because their skin is kind of poor quality. If they're younger and they have some motion, even if it's just pain with end range of motion, like pain with maximum dorsiflexion, they got a little spur on the top, but they got a bunion. The cool thing with MIS is because of the width of the burr, and I don't lengthen them. Like I'm assuming you don't try to lengthen them either. Maybe I'm wrong. They get a little bit of shortening. So it's shockingly been phenomenal for that grade 2 hallux regius with the bunion.
Right.
So I'll do the bunion and then I'll just shave off the little bit of the top, and they've done really well. I don't know if that's been your experience.
Yeah, definitely. Younger patients, definitely. If the DJD is not if this wasn't an 80-year-old, the one on the screen right now, I'd probably still go with a fusion if they're younger. But yeah, I agree with you. Definitely it decompresses the joint a little bit for them, so it does help.
So I did a fusion. I don't want you to watch you think I'm that nuts, okay? Because sometimes I know. So this was an 83-year-old, same thought. Do you do a bunion? Do you not? But she was older, and I felt, look, I need a fusion, but I did not want to get a wound complication at all. It was not an option. So I did this medial approach MIS fusion with 3 different, these are all arthritic screws. You can do any combination you want, 2, 3. I use snap-out pins a lot too now as an adjunct. But how was your experience? I think these do amazing. That's what I wanted to get out. Like this MIS fusion does great. If they're a big individual in their 50s, I'll still open them.
Yeah, revision, I'll open them. But I think older patients, I definitely try the cross screws.
This is Dr. Patel, David. Give me 1 sec. Let's see if he'll join us. Do you want to join us? Podcast? Okay. No problem. We'll finish without you. Don't worry about it. Dr. Patel is unavailable. He's sleeping with his children, which is, God bless him.
Sunday night,
Sunday night. There's, for all of you out there, we all got families and stuff. And so, families first,
Yeah, for sure.
So,
for older patients, cross screws, trying to find if for whatever reason they get like a non-union something, a lot of times I'll open them up. I know, remember that study that was saying like what construct's the best, a plate and a screw versus 2 cross screws, those kind of things. So when I first started, when I did cross screw, I was like, well, I mean, people used to do this all the time, open, right, with cross screws, and they heal, but it's not the best construct. But if for whatever reason patient's not compliant, they're walking all over it, it got a non-union, then I'll do the plate and screw and I'll open them up. But I mean, some people have proposed doing like a meeple technique with the plate. They slide them in. There is a company out there that has like a little jig on top, so you can kind of aim your screws onto the thing, which is kind of cool. Very good idea. But I don't know. I mean, I might still change the game. I mean, if I don't have to open a big incision, I won't. So, yeah.
I'm with you. I mean, I just the screw technique works great, and that's why I added a 3rd screw because of that article. 2 cross screws. The problem is you get cross screws in. So what I put my cross screw, I go dorsal medial, typically proximal to distal lateral. Then I go plantar medial, trying to not get them exactly in the same plane on the lateral. But I like adding a 3rd screw somewhat oblique because that ensures that the center of rotation where they cross is the screws don't cross at the center of rotation, right? I got some obliquity, makes them more rigid. Right. Another thing that I've been doing for like my more proximal major fusions for the toe, you can do it too. Do the whole thing MIS, get your wires in, get the screw in, and then you're like, man, I think I want more. Just extend your incision a little bit. And if you go medial, I make a vertical one, but you can just zigzag it and throw a staple on. Like throw a 15 millimeter staple on there. You're not making like a 7 centimeter incision, right? You did the whole thing. You've got all the slurry inside. Put a staple on. Yeah. And that gives you that extra fixation. So I think when we think about MIS fusion of the big toe or any MS fusion, it's not screw only, right? You can still make a small incision. You're not taking all the periosteum down and all its work. Got to get a little staple on there and be done with it. And you can see like my lateral, like different planes.
I think I saw this on Instagram. Didn't you post that once?
I did post this on Instagram because this was like one of the first ones I did. Man, it's pretty cool. And she did amazing. I'm not saying it's cosmetically perfect, but healed. I mean, 6 weeks, no pain.
It's great.
I mean, look, where's the wound, right? So you start realizing where's the wound. It's unbelievable. I don't add biologics to these fusions. I don't know if you do. Do you, in a straight up fusion MIS, are you adding anything?
For first MPJ, depending on bone quality, sometimes I'll inject some of this. We have a spine surgeon that works out of our surgery center, and he always has DBM putty, and I'll just
throw it in there.
Little injection there. I will say, like for the bigger joints, sometimes it's because there's more soft tissue in the way. It's a little harder to inject the DBM or whatever inside the joint itself, and so I almost like, I'm spending more time trying to stuff that thing in there than actually burying it down and doing all that stuff. Yeah.
So this is another fusion just to show, hey, you can do this lots of different ways. I did the DMMOs. And so this was a rheumatoid patient, no wounds. And you can just see here clinically, like multiple surgery, but no soft tissue injury. And so I think like this is getting close to the end, but I think the journey for MIS it's a little bit of a struggle at the beginning. Wouldn't you say, David? I don't think it's like, oh man, this is super easy. That's not what I'm saying at all.
Right. I would encourage people to do it like open to start if they're really not trusting themselves.
Yeah. Use the burrs tool, right?
Construct, but just open it,
I think that's a great idea. Anything you don't know, use the burr. The burr is a tool. It's not like MIS is a tool. It's not the only way to do something. So you can prepare a joint with the MIS burrs open. get
Yeah.
used to the burr, see what it does, practice in the lab. There's another case, a perineal cavus case, not CMT, but acts like it because it has some perineal nerve damage. So one of the things that I always struggled with was like that lateral incision, right? You got to do your perineals, your Brostrom or Evans, and the
Yeah.
calcocyotomy incision was like, do you make two parallel incisions? People say it doesn't matter. I've gotten away with it. We
Right.
get away with a lot of things, but my concern is what happens when I don't, right? So now calcocyotomy is a chip shot. First time it took me a long time. Now it's like 10 minutes to do this case. You can see the burr goes in, it's bloody, you get your water going. But look at the shift you can get. That's the start. It's all MIS. I do a closing wedge. So I'm not here to
Right.
talk about like how to do the calcocyotomy too much, but I think for me it's changed everything for patient safety. Speed is great too. And things heal because you haven't taken the blood supply. Like when's the non-union rate, if you did a good job, if you took
Yeah.
the joint down, is pretty low, right?
Agreed. I think you just have to have the right burr too, because if you pick the wrong burr, um, and there are burrs that are not as sharp as some other burrs, so
Yes.
you gotta make sure you're picking the right one.
So
Don't just let
for
the tech hand you the burr.
correct, you
Make
gotta.
sure you know. Yeah.
We should probably go through the burr. So just before we get this, like the last thing that we have, but like, so there's a Shannon burr, and for me, in my mind, the Shannon burr is that triangular shaped burr. That's for cutting through the bone, osteotomies, or getting like the first start of a fusion. Is that how you use it?
Yeah. I'll just to get in the joint, get a little burring going, and then sometimes I'll switch to wedge after. So the
Exactly
wedge
what I
is my favorite for fusions. They work
Wedge
so
is amazing.
fast.
Yes. So I think for all of you here that are going to try a fusion, like the Shannon is your starting burr and that's your osteotomy burr. That thing is awesome to cut through a bone. The problem is when you use a Shannon to try to finish your fusion, it kind of goes into the joint and starts cutting into bone randomly. The wedge burr is a great burr. It usually won't cut into the bone. It'll just kind of
Yeah.
side cut the bone. And so
Do you use
that's
the
like,
Shannon to fenestrate, or do
I I
you'll
haven't.
still do the K wire? Go in there.
I don't do anything. Once I've got
Oh,
that and I
okay.
can smash it, I don't do it. But I think if
Yeah.
you're having a harder time, I was at our first AOFAS MIS course, and
Mhm.
that's what I was telling people to say. You can also just fenestrate it if you need to. I hadn't had the need yet,
Right.
but I think that's a great option to just take the burr instead of going sideways, just attack
Jam
the
into
bone
the
and
bone.
put it in there,
Yeah.
man. Why not? Actually,
Yeah.
so these are two of my main mentors, and Armin at his stage in career is doing MIS, and his line was flexible thinking but have rigid fixation. And I think
Right.
that's a lot of MIS, but funny, there's a lot of things in MS we don't have rigid fixation. Just to be clear, like DMMOs, which we'll get into in another podcast for the lesser toes, but those have no fixation, right? So
Yep.
let's always
Straight up
apply.
onions. Yeah.
And then Mark taught me, if you do what I taught you the same way in 5 years, you have failed. And I think that's an
Yeah.
important lesson. Not that you abandon everything you learned when you trained or what you did 5 years ago, but I think the key is, I got 3 FAIs sitting next to me here on the floor. I got to finish reading. Like you got to keep reading and you have to go to courses. You just have to adapt. I think that's what makes you a better surgeon, makes the job more fun too. It's good for the patients.
Right.
I presume you think the same way because you're clearly on like the cutting edge of a bunch of stuff.
Definitely. Yeah. I mean, part of the reason I created 15 Blades was, I don't mean to promote that here, but like part of
It's
the
all
reason
right.
I created it was because people are, a lot of surgeons, especially in private practice, you don't have access to these journals. You're not part of a university setting. You got to order these journals yourself. Like you're just not part of it. And
I mean,
so you have to go to these courses. You have to, see what other people are doing, learn from them, so.
I think that's key. I mean, that's why I do the Instagram, right? It gave education to everybody. That's why we're doing the podcast.
Right.
Yes, we talk about script on the podcast as well, which is the AI dictation system, Blades. It's all about, making our lives as surgeons better. Yes,
Yeah.
we've developed a lot of these things too, but a lot of it is to share information. I mean, we do this to share information, make everybody's life better. And I
Right.
think that's, MIS is one of those things that it's going to be this way in 10 years. We're going to talk a lot about it on this podcast. There's a lot of courses to go to, and it's probably the biggest change in my practice in the last 5 years, I would have to say.
I agree. I will say also kind of put me on the map where I am because nobody else does them.
Yeah.
And I was doing them. And so when patients start seeing that their incision's so small, cosmetically pleasing, they'll start referring their families, their friends. They're like, hey, go to this guy instead of the big incision, go to this guy, So
it's a great marketing tool. Well, thank you very much. I know we took a long time today for this, but it's such a huge topic. I wanted to make sure we touched on it, and we're going to really start talking about it too for the hind foot, midfoot, lesser toes, when it should be used, when it can't be used. And then in addition to all the crazy revision stuff that we do too, obviously. So thanks a lot, David. Appreciate it.
Yeah, for sure. Thanks for having me on.